Hello and welcome to the webinar. I'm Barbara DePietro, the Council's Policy Director, and I'll be acting as moderator for today's webinar, Medicaid Eligibility, Enrollment, and Outreach, Changes Coming to the HCH Community, a production of the National Healthcare for the Homeless Council. This session is being recorded, and the archived version will be available on our website by tomorrow morning. This is a 90-minute webinar, and we'll reserve the last 15 to 20 minutes for questions and answers. Let me spend a minute talking about logistics. You'll see below the presentation slide that there's a chat box for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation, and we'll attend to the technical issues immediately and try to answer as many of the questions as possible at the end. We'll also be using these questions to inform a plenary discussion at our upcoming conference being held March 14th to 16th in Washington, D.C. All participants have a full screen button located on the bottom left of the PowerPoint presentation. You may use this to resize the presentation to full screen, but you will not be able to see or access the Q&A chat box. To enable that view, simply re-click the full screen button to revert to the original view. Today's webinar will discuss the numerous changes that are happening with regard to Medicaid and how these changes will impact the healthcare for the homeless community and those patients that we serve. It's our pleasure to have 4 distinguished national experts on these issues. Please let me first introduce Anne-Marie Costello and Stephanie Bell. Anne-Marie is the Director of the Division of Eligibility, Enrollment, and Outreach for the Centers for Medicaid and CHIP Services at CMS. And Stephanie is the Technical Director in that same office at CMCS at Centers for Medicare and Medicaid Services. Stephanie and Anne-Marie will talk about changes in eligibility and the new system of coverage that's being developed, the streamlined enrollment process and the new application, and the process improvements and the assistance that will be available. Next, Kevin Malone, who's a public health analyst at the Office of Policy Planning and Innovation at SAMHSA, we'll talk about the behavioral health needs of those who are newly eligible for Medicaid, the marketing and research findings that have been conducted, the SAMHSA initiatives, training, and resources that will be available. And finally, Jessica Kandal, the Outreach Director for Enroll America, will talk about the national goals, the mission of Enroll America, and the best practices being developed. She'll also talk about reaching the uninsured and the research findings that Enroll America has conducted, and the role of health centers and the resources that will be available to us. Then we will talk about questions and answers. All of this will be just a quick overview, but first let's just talk quickly about where we are as a baseline with the disparities in health insurance status, even when you compare healthcare for the homeless clinics to regular health centers and then compare that to the general public in the United States. Using 2011 insurance data from the UDS, which is the health center reporting data set, you'll see that 62% of the 825,000 patients that Healthcare for the Homeless grantees have served, nearly 2/3 of those are uninsured, and that's compared to 36% in regular health centers. And of course, you can see the disparities with the general public. And so we see that those who are healthcare for the homeless patients really have a disproportionate stake in the changes in insurance eligibility and the new enrollment streamlining that's happening. The reason this is important is that the new insurance opportunities are really going to improve patient access to comprehensive health care. But these also fundamentally change our health center operations, so really appreciating how this is going to impact both administrative practices as well as clinical practices and patient outcomes. We're going to see a lot of changing of traditional barriers to enrollment. So things that healthcare for the homeless community is familiar with in terms of the lost paperwork, paperwork that doesn't exist, complicated or fragmented eligibility standards, long and complex enrollment forms. A lot of that is going to be changing. And so some of those traditional barriers that we've experienced in the past, we hopefully won't see going forward, which is an exciting development. We'll also see health centers being critical venues, not just for doing the enrollment itself, but really doing a lot of patient education about the changes that are happening and how those can really be of a benefit, doing outreach and really engaging people in the health services that we know they need in order to stabilize their health. We know that there will still be challenges in the new system, and I think what we're hoping to do is learn here what the changes are so that we can best identify and overcome new challenges that might emerge, again, because we know that a vulnerable population will always have some accommodation that needs to be made. But really, we'd like to know that the system improvements, the new access to care, hopefully will really yield some significant improvements in health. And we're hoping that that yields better stabilization in our clients, and in doing so, maybe we can see some progress toward preventing and ending homelessness. So this is the context within which all of this is happening. We're seeing the opportunities, but we also want to be mindful of the ongoing challenges and develop strategies to overcome those. And so with that as a quick introduction and overview, I'll turn it over to Stephanie and Anne-Marie at CMS.
Great. Thank you, Barbara, and thank you to the Council for inviting us to join today's webinar. We're very excited to talk about the opportunities that the Affordable Care Act affords us in expanding coverage to Medicaid and CHIP eligible individuals and families. I thought it would be worth taking just a moment to take a step back and just take a look at sort of the big picture around what's going to happen in increasing access to coverage. The Affordable Care Act really laid out three key prongs to increasing access to coverage. The first is it establishes the health insurance marketplaces to help individuals apply for and purchase coverage. And what that really does is not just create another way to get health insurance, but it will create a much greater presence and make it easier for individuals to apply for health insurance coverage, and regardless of what they may be eligible for. And I think that's critically important. It really does open the door to allow more opportunities for enrollment. The exchanges will be key players in eligibility and enrollment come October 1st, 2013, which is the first day of open enrollment and when exchanges will begin to be operational. The Affordable Care Act also provides for premium tax credits to support the purchase of health insurance coverage through an exchange. We'll talk in a couple of minutes. I'll just show you where the eligibility levels for an individual can begin to access advanced payments of a tax credit, and where Medicaid eligibility begins and ends, and where eligibility for coverage through an exchange begins. The third important prong that the Affordable Care Act does to increase access for coverage is that it builds on and simplifies the Medicaid and CHIP program. And for those of you not familiar, CHIP is the Children's Health Insurance Program, and it's an existing program that's been around for well over a decade now that expands Medicaid eligibility for children and sits on top of the state's Medicaid programs. And the Affordable Care Act not only simplifies Medicaid and CHIP eligibility and takes the patchwork framework of eligibility and enrollment rules that, to the great extent, practice varies greatly from state to state, and really sets out a far more fundamental approach to health insurance enrollment. It also expands eligibility and covers individuals who had never had the opportunity to be enrolled through the Medicaid program, primarily those being adults without dependent children. They were categorically excluded from Medicaid eligibility in the past. Some states used state-only funding, and some other states used waivers to cover this population, but a great many states did not cover this population. And the Affordable Care Act makes this an opportunity come 2014. I really think taken together, these coverage programs ensure that individuals have access to important health insurance coverage and can get the care they need when they need it. We really talk here a lot about a seamless system of coverage. Historically, there have been stair steps to eligibility, so eligibility levels have varied by age. They certainly vary by states. Medicaid is a partnership program between the federal government and the state Medicaid agencies. State Medicaid agencies operate the Medicaid programs under a broad federal framework where we set minimum standards, but then states have lots of flexibilities. And as a result, we had varying eligibility levels, and we also often had gaps in coverage for individuals. And what you see here is a snapshot of a seamless system of coverage. And if you just look at the left-hand side, you see the adult row, and you see Medicaid for adults from 0 to 133% of the federal poverty level. Sitting on top of the Medicaid program for adults, you see the ability to have subsidies through the exchange. And what the subsidies means is an advance payment of a tax credit to help support purchasing of health insurance coverage. There's also the ability to have cost-sharing reductions for individuals. So there's help for an individual up to 400% of the federal poverty level. When you look at children, children's eligibility historically has been far more generous in the Medicaid and CHIP program. So you see children have higher eligibility levels. They do vary by state, but the average eligibility level across the states is about 240% of the federal poverty level for children, so higher than adults. But again, sitting on top of the Medicaid and CHIP program for children is the ability for children whose families don't qualify to have them enrolled in Medicaid or CHIP, the opportunity to take advantage and receive subsidies through the exchange through an advance payment of a tax credit to enroll in a qualified health plan. And so really, this really tries to minimize the gaps in coverage for many individuals. So what are some of the changes that are coming in 2014? I think Barbara eloquently laid out some of the opportunities we have before us, but we really are dramatically changing not just eligibility requirements, but how people apply, how individuals verify their eligibility, where people can apply for coverage, how they can apply for coverage, what are the requirements of the Medicaid and CHIP agencies for how they coordinate and interact with each other and with the exchanges so that we can make sure that people do not fall through the cracks just because they choose to apply at one program and not at another. You'll hear a lot more. Stephanie Bell is really going to focus on the application, enrollment, and eligibility process because I think there are truly fundamental changes to how people will be able to access coverage. And that's sort of the first bullet on this page is a simplified Medicaid and CHIP eligibility and enrollment process. The Medicaid and we here at CMS issued final eligibility rules for Medicaid and CHIP agencies in March of last year, which really lay out the things that we're going to talk about today. A little bit more on the expanded Medicaid eligibility. As I mentioned before, the Affordable Care Act makes available a new group for a new eligibility group in the Medicaid program. We fondly call them the adult group. Individuals are eligible in this group if they're between the ages of 19 and 64 years of age, and they are not eligible for Medicare. This group does not include pregnant women or children because there are other eligibility groups that have the same eligibility levels. So this group is really for the adults who could not be eligible under another group. Again, eligibility for this adult group goes up to 133% of the federal poverty level. And for the first time in many states, will make coverage available to adults who do not have dependent children. Because as I said earlier, a large number of states do not provide coverage to these individuals because they were not what we call here a state plan group. So there was not federal financial participation to support coverage for many of these adults. The Affordable Care Act makes enhanced funding available to states to cover individuals in this new adults group. For individuals who are newly eligible in the adults group, there is 100% what we call FMAP, and so actually the federal government pays for 100% of the coverage for these individuals for the years 2014 through 2016. Then our federal contribution decreases slightly and moves down to 90% by 2020. And so there is always an enhanced match, which is an incentive for states to cover these individuals and take up this new adult group. There's enhanced funding to help cover the cost of providing health insurance to this group of individuals. The Affordable Care Act and our Medicaid and CHIP regulations move to the use of MAGI for most individuals. So what does MAGI mean? MAGI stands for Modified Adjusted Gross Income. I hope you never have to say those words again, but we all go by the term MAGI. And basically, MAGI is the eligibility groups who were in the past what we think of today as the children and families groups. So really, everyone enrolled in Medicaid will have their eligibility determined on a basis of MAGI, with the exception of individuals who are either aged, blind, or disabled. So really, it's a new set of rules related to how we count income and household composition, so who's in someone's household, Medicaid household, I should say, and can be on an application together. Different than how it's done for the age, blind, and disabled population. But it moves towards more standardized approach across the states.
And the same, or almost the same methodology that the exchanges will be using to determine eligibility. So there's some consistency between Medicaid, CHIP, and the exchange.
That's exactly right, Stephanie. I think we really strived very hard to make sure that we had the same sets of rules across Medicaid, CHIP, and eligibility for the exchange. We have learned many lessons over the last decade. When states have different eligibility rules for their Medicaid program and their CHIP program, children would fall through the cracks. So we worked very hard that wherever possible to have the same and consistent eligibility and enrollment rules across the insurance affordability programs. So it really could try to minimize those gaps in coverage. I think that's very important to note. Leading to that, we also have standards to ensure coordinated, accurate, and timely processing of eligibility determinations and data sharing across states. And what that really means, and Stephanie will describe this more in detail, but we have laid out regulations related to how an application must be accepted, when eligibility must be determined. If a Medicaid agency finds that someone is not eligible for Medicaid, their job is not done. Today what happens is they issue a denial of eligibility. What will happen come 2014 is that if someone is not eligible for Medicaid, the Medicaid agency still has the responsibility to assess that individual for eligibility in either the Children's Health Insurance Program or for enrollment in a qualified health plan through an exchange. And then once they decide what that person may be potentially eligible for, transfer their account, which includes all of their application data, all of the verification work that's already been done, to that appropriate agency so they can complete the eligibility determination. No longer should individuals who are applying for coverage have to try to figure out what door they need to walk through to apply, and that whether they should be shuffling papers between agencies. It is the responsibility of the agencies to coordinate and transition information across programs so that regardless of where someone applies, they can get an eligibility determination. And I think that's critically important for us. And I should also say a timely eligibility determination. We can't have delays in coverage because application data is being transferred across programs. We still need to assure a timely eligibility determination. The last point here on this slide, I think, is another significant one, particularly for the populations that you work with. Today, Medicaid eligibility must be renewed at least once a year. And what that has resulted in many states is that some states have requirements that people need to renew their eligibility more than once a year. What we have for individuals, starting in 2014, for individuals whose eligibility is based on modified adjusted gross income, they will have their eligibility renewed only once per year. So again, we think that is a way to ensure that eligible individuals stay enrolled and do not churn on and off the programs. Historically, states have found that many individuals lose coverage at renewal simply because somebody failed to provide their paperwork back to the agency in a timely manner, and they were denied, their eligibility was terminated. The individual will go uncovered for some number of months and within a short time be right back in applying for Medicaid coverage and still be eligible. So we really have tried to smooth out the renewal process so that eligible individuals can stay enrolled in the coverage that they need. We've also simplified the renewal process. So before a state can go out and just send an individual a form to complete, the Medicaid agency must first use the information available to the agency, whether through electronic data matches or other information available in the individual's case, to redetermine eligibility. If the state has enough information to renew eligibility, they're done. The individual never has to take an action. If the agency does not have enough information to continue eligibility, they then must send a pre-populated renewal form. Again, this is an effort that really grows on a lot of the best practices in a number of states who have really worked to streamline and simplify the renewal process and really codify long-standing practice. So really try again to streamline the renewal process for individuals, because this is more than just getting people in the front door to coverage. It's keeping eligible individuals enrolled as well. We think that's a critically important goal, and they need to come in partner. Enrollment and renewal need to be partners in this effort. I thought it would be worth just taking 1 second showing you in federal poverty levels, eligibility by the different populations. So looking at what's the average current eligibility level today in Medicaid and what it will be in 2014. So for the population of children and pregnant women, it varies slightly depending on the age of the child, but most children are eligible either up to 100% of the federal poverty level, so 6 to 18-year-olds, federal regulations require that they be eligible for Medicaid up to 100% of the federal poverty level, and children 1 through 5 years of age up to 133% of the federal poverty level. We also know that there's a minimum standard that pregnant women be covered up to at least 133% of the federal poverty level. Many states cover pregnant women at even higher levels than that. And as I said earlier, many states have far more generous eligibility levels above the federally required minimums, and the average is about 240%. Come 2014, the floor for eligibility is 133% of the federal poverty level. So even those children 6 to 18 years of age whose Medicaid eligibility is only up to 100% of the federal poverty level, that increases to 133% come January 1st, 2014, and really trying to do away with that stair-stepped approach to eligibility. For parents, parent eligibility varies greatly by state today, with an average at about 64% of the federal poverty level, and our eligibility minimums will be 133% of the federal poverty level. Again, for disabled adults, eligibility again is around 74% of the federal poverty level. Some states do have higher eligibility levels, but even individuals who are disabled, if they meet the other eligibility criteria, can be eligible for the new adult group and have eligibility at 133% of the federal poverty level. Other adults, so again, primarily adults that do not have dependent children, as I said earlier, are not covered in many states, are not covered in all states, and the new adult group available under the Affordable Care Act provides eligibility up to 133% of the federal poverty level. Again, the asterisk just notes that these are states that take up this option for the new adult group. And I think what you really see here is the Affordable Care Act really sets a new floor for Medicaid eligibility at 133% of the federal poverty level. I'm going to turn now to Stephanie Bell, who's going to talk about the streamlined eligibility and enrollment process.
Great. So I think one of the biggest changes established by the Affordable Care Act is the move to a streamlined eligibility and enrollment process for Medicaid, CHIP, and the exchanges. And as you'll see, if you look at the box on the left, The process starts out when the individual submits a single streamlined application, and that can go into the exchange, Medicaid, or CHIP. An individual can do it online, by phone, through the mail, in person. So the Affordable Care Act requires that states establish an online portal through which a person can apply. And again, that the application has to be include enough information to determine eligibility for all three of the programs. So an individual or a family doesn't have to fill out multiple applications. So the next box shows eligibility is the box in the middle, eligibility is verified and determined. This is kind of misleading in that it's showing it coming after the application is submitted, because in effect, through the online application process, we've set up basically a smart application. So as the individual is going through and filling it out, and they're entering their information, say they put in their Social Security number, well, that information will be able to be sent directly through what we're calling the Federally Managed Data Services Hub, sent over to Social Security Administration and verified, ideally in real time while the person is filling out the application, so that by the time they've completed it, if all of their information checks out, they could essentially have an eligibility determination at the end of the process. And that would be a determination for Medicaid, for CHIP, and for enrollment in a qualified health plan. The last step in the box is enroll in affordable coverage. And this is going to depend in part on how a state sets up their programs as to whether an individual would be able to enroll immediately or not, and also what programs they're eligible for. So, all states are required to either establish an exchange or to work with the federally facilitated exchange that we are putting together here. And depending on the process that they choose, if a state sets up their own exchange, they can create one system that through which an individual applies, and there's just one eligibility system that determines eligibility for Medicaid, for CHIP, and for the exchanges. They could all be in one agency, or they could be setting it up such that the exchange is in a separate agency, but they have kind of coordinated systems. And in a state like that, they could have the whole process be in kind of one box, and you could go from start to finish for all of the programs in one place. In states that maybe aren't quite, that are setting up their exchange but it's not quite ready, or else they're not quite sure what process they want to use, and maybe they're using the federally facilitated exchange in the beginning, there'll be a slightly different process. So if an individual applies through the federally facilitated exchange, there'll be two options that the state can pick. They can either have the federally facilitated exchange do complete determinations for Medicaid or CHIP. So the applicant goes in, fills it all out, the federally facilitated exchange determines the person is eligible for Medicaid. Then they would have to, their account would be transmitted electronically over to the Medicaid agency, and the enrollment process would take place there. States can also elect the option to only have the federally facilitated exchange do an assessment, which would be basically an almost identical process, except that the applicant's information would be sent over to the Medicaid agency, and Medicaid maybe does one or two additional verifications. You know, if they have a state data source that they like to use, that they want to conduct maybe an additional income verification, they might do that, and then they would determine the person officially eligible for Medicaid and move to plan enrollment. So in terms of enrollment, really nothing's changing from the current process around enrollment, but what's changing is really the eligibility process, and really streamlining it such that it's the same across all three programs, so that, you know, it doesn't matter which door you go in, that you'll be able to get a determination for all three programs.
And Stephanie, I just think that that's worth saying one more time, that this really builds to the approach of no wrong door, that regardless of where an individual submits an application or how they submit the application, whether it's online, by phone, in person, or mail, regardless of who receives it, a Medicaid agency, a CHIP agency, or an exchange, that individual will have their application processed and their eligibility determined. The application may need to move across agencies, but that should happen seamlessly, and the individual should not need to interact with a great many people to make that happen. There are requirements that help to move this process through.
Yes, thank you. Let's go to the next slide and talk a little bit more about the application itself. So the Affordable Care Act requires states to utilize a single streamlined application, again, through which you can apply for Medicaid, CHIP, and coverage through the exchange. And the Secretary is charged with developing a model application. And this is also the same application that will be used by the federally facilitated exchange. So we've been spending a lot of time working on the application, both the online version and the paper application. And as I said, so the online application is a smart application. So as you answer questions, it will bring up the appropriate questions based on your previous responses. So if it's looking like the individual is going to be Medicaid eligible, they would be directed to answer only the Medicaid questions, and they wouldn't be required to fill out anything about employer-sponsored coverage for things that would be required only for coverage through the exchange. So it's going to be a much easier process for individuals. The paper application that we're developing is also simplified and streamlined, though obviously it can't be a smart application. But we have done a significant amount of consumer testing on both the paper and the online. And based on some of that feedback, we've set it up in a slightly different way than a typical Medicaid application, such that it's based on individual, so you start out by filling out the information on the application filer, and then it goes through each applicant and asks questions about that applicant and their income. And we found from consumer testing that this has been a much easier way for people to understand and fill it out. So individuals will be able to, states can use the model application, or they'll also be able to develop an alternative application with secretarial approval. And there are a couple of requirements for alternative applications. They can be no more burdensome than the application developed by the secretary. They again have to ensure coordination across programs, so they have to be for Medicaid, CHIP, and the exchanges. And states also will have the option of including other benefits. So I know a lot of states have multi-benefit applications now, and we're working on what kinds of questions and additional criteria would need to be added to our current models in order to broaden them to be a multi-benefit application. And then again, the application can be submitted through multiple multiple channels, so online, over the phone, by mail. So turning to the verification process, this is another, I think, really exciting change in the way that the Medicaid agencies will be doing business, and I think something that will be particularly of interest to you all, because it requires primary reliance now on electronic sources, and in today's world, there's so many requirements for producing paper documentation, pay stubs and birth certificates and things that that I may not be able to find in my house. So an individual who is homeless is probably going to have an even more difficult time finding access to. So there are new requirements to start with electronic data sources. There'll be a single electronic source for multiple verifications, again what we're calling the hub. And the hub will be linked to the Social Security Administration, the Department of Homeland Security, and the IRS. So as people are filling out the online application, it can do that direct checking with those entities for citizenship information and for income information and for immigration status. And then again, a decreased reliance on documentation and an increased reliance on self-attestation. So we're really encouraging and giving states new opportunities to use self-attestation. So individuals cannot be required to provide additional information or documentation for things that could be reasonably accessed electronically. So states now can, in 2014, will be able to use self-attestation of virtually everything except citizenship, immigration status, and I believe Social Security number. So they can accept self-attestation then of residency. No longer will they need to require an individual to bring in a piece of mail to show that they're actually a resident of the state.
I think really what it really does and what we try to lay out is really turn almost on its head the way the verification process happens today. And many of you on the phone, I'm sure I've helped individuals apply for Medicaid, and you fill out an application and you gather some documents. If an individual has any of those documents, Stephanie gives a perfect example of a postmark canceled envelope to prove your residency. You bundle it all up and you submit it, and then a Medicaid eligibility worker uses electronic data sources behind the scenes to verify the paper documentation. And what we really do is turn that on its head and say, start with the electronic first. And only if you can't get it through electronic data, or if the electronic data is not consistent with what the individual says on their application, can you then go to paper. And so it really does take the tools that are already available to Medicaid agencies and just switches the order of when they use them. So electronic first, paper second. And always the ability to do self-attestation was always an option for certain factors of eligibility. This just gives it a better place for states to be able to accept that. Next.
Yes. So last but not least, we just wanted to touch on enrollment assistance and note that agencies may certify application counselors to provide assistance with applications and renewals. And in our notice of proposed rulemaking that we just recently released, we did provide some regulations around application counselors, previously known as application assisters. We're not really creating any new requirements around those. The application counselors, we're really just codifying in regulation the standards that states have had in effect for those individuals. So, to be certified, counselors must be registered, trained in the rules of the insurance affordability programs, and understanding the safeguards and security of information.
And again, I think we've proposed these rules, as Stephanie said. Many states have relationships with organizations to help with application and renewal. In some states, it's a formal relationship where they give grant funding. Other states, it's a different kind of formal relationship. They might have an MOU with, say, a provider, so the provider can submit applications. In other states, it's far less formal than that, and almost what we call sort of kitchen table assisters. So they just sit with someone and they hand the application back to the individual, and it's the individual's responsibility to submit the application. With the move to an online environment and the move to a smart application that embeds the verification process within the application, these application assisters or counselors will have access to confidential data sources because it's part of the application process, it's embedded in the application process. So to that end, to ensure safeguarding of this information, that's a great part why we've also proposed these rules. This provision was in a proposed rule that was out for a comment period that closed last week. So we are working now to move to finalize regulations related to a number of things related to Medicaid.
And I just wanted to note before I hand it over to Kevin that the application is open for comment until tomorrow. So if you all have an opportunity to go on to Medicaid.gov, you can click on links to see the online model of the online application and also the paper application. And we would encourage you to comment on it as well. And now I'll pass it over to Kevin.
Thank you very much, Stephanie and Anne-Marie. It's my pleasure to have a chance to follow up on that awesome presentation. My name is Kevin Malone. I work in the Administrator's Office of Policy Planning and Innovation at the Substance Abuse and Mental Health Services Administration, a different operating division of the U.S. Department of Health and Human Services. I really am grateful for having the chance to present with Anne-Marie and Stephanie. They, as I'm sure you've just heard, are responsible for overseeing some of the most extraordinary changes to the way in which we provide access to health insurance coverage in our nation's history. And I really can't emphasize enough how important the changes to the application and enrollment process are that they just explained. And their work is really incredibly important, and we're all very fortunate to have a chance to hear from them today. And it's really, frankly, a testament to the leadership of the National Healthcare for the Homeless Council that this whole group has been able to get pulled together, and Barbara in particular, Barbara DiPietro, has been a extremely enthusiastic and excellent leader in the work related to enrollment and eligibility through the implementation of the Affordable Care Act for the last 2 years. And it's my pleasure to have a chance to speak to you all today. At SAMHSA, we have been extremely focused on enrollment as a priority for our work related to the Affordable Care Act because, as I'll share some data today, the newly eligible uninsured are disproportionately likely to have a behavioral health need. And we really are going to depend on organizations like yours to really fulfill the promise of the Affordable Care Act that we just heard about in the sort of expansion of eligibility. So today I'm going to highlight very quickly the sort of prevalence rates that we have projected of behavioral health needs among the newly eligible uninsured, some high-level marketing research that we have done in some partnership with the CMS Office of Communications to sort of build on the incredible investments they've made in marketing research around communicating to the newly eligible uninsured. And then I really want to spend the majority of the time allotted to me today on some initiatives that the SAMHSA is trying to put together that really will make this presentation you hear today the first of multiple steps to try and help you and the professionals that you work with and the communities where you work be able to capitalize on the opportunity to enroll uninsured individuals in coverage. As you heard, even though there are dramatic simplifications in the application process, there are also complications. And for individuals who may have no income or who may have be experiencing homelessness, maybe experiencing serious mental health issues and chronic substance use problems, even navigating the tremendously simplified and improved application process that Anne-Marie just described to us is going to present some issues. And as you've seen, I'll be able to share from my research, they're going to depend on you and the folks that work for you to help make sure that they get covered. So quickly, as you heard from Anne-Marie, based on where public health insurance through CHIP and Medicaid cover folks now, that's represented in who the uninsured are. Most folks get coverage from employer-sponsored health insurance, and as you can see, the majority of the uninsured are going to be eligible for coverage, subsidized coverage, as a result of the Affordable Care Act. Demographically, this is not surprising. This echoes exactly what Anne-Marie explained about who is categorically eligible for public coverage now. And not surprisingly, the prevalence rates of behavioral health conditions among the uninsured are high. There's almost 30%, according to the National Survey of Drug Use and Health, of the uninsured individuals below 400% of the federal poverty line are currently experiencing a behavioral health problem. Anne-Marie did emphasize sort of the improvements in the application and redetermination process. And we've seen some research that SAMHSA has done in Massachusetts that individuals in the state, even that has full expansions in eligibility, if the improvements in the application and enrollment and redetermination process that they described, if those improvements don't happen, the promise, especially for those with the most chronic behavioral health problems, is not often fulfilled. You can see that in a state where 97% of the overall population is covered, 20 to 30% of patients seeking acute behavioral health treatment are uninsured, and especially for those, and especially young men with substance use problems. And I'm sure many of those young childless adults with substance use problems are individuals that you serve in your centers as well. This third bullet on individuals who are avoidably disenrolled, that addresses the issue that Anne-Marie mentioned about churning, where individuals are disenrolled avoidably and have to re-enroll in the same program. Hopefully the improvements that my colleagues from CMS highlighted to the redetermination process will significantly reduce this problem. From a prevalence perspective, you can see that for the Medicaid expansion, there's a significant prevalence of mental health issues and substance use problems among the uninsured. Almost 15% of the uninsured currently in the United States are experiencing serious psychological distress, and more than 14% currently have a substance use disorder, which for those of you who are not familiar with those categories, a substance use disorder is significantly higher than just abuse. It is dependence. So and serious psychological distress is based on the K6 and corresponds to meeting a clinical criteria for a mental health condition. You can see it varies fairly significantly by state of the prevalence among the uninsured. And if you visit SAMHSA's website under the health reform page, you can find state-by-state prevalence estimates for the data that I'm sharing today. Similarly, this is the variation across the nation of substance use disorders among the Medicaid-eligible population. Demographically, there's an interesting breakdown between individuals who have a serious mental illness among the uninsured, who are going to be eligible for Medicaid, and those who have a substance use disorder. Those who are going to be eligible for Medicaid are somewhat more likely to be female, and they're more likely to have other health problems than other individuals. For individuals with substance use disorders, they're disproportionately likely to be young men who have fewer primary medical conditions. So this population is going to present a significant challenge for outreach and enrollment assistance because they may not be utilizing primary medical services and only may be accessing care in an acute setting. And so the utility for them of accessing coverage, especially if they may be exempt from the individual mandate, may present a significant enrollment challenge, and we're going to depend on organizations like yours to make this happen. This is another representation and helps compare the differences between the exchange population, where the self-rated health is somewhat better. We have also done at SAMHSA a set of marketing research that I alluded to earlier that sort of reaffirmed the research that CMS has done about how to communicate to uninsured individuals about health insurance. We found that most uninsured individuals are unfamiliar with health insurance and its utility. Many of them who are currently eligible don't know it, and some of those, and almost everyone who is going to be eligible for the first time starting this year, at the end of this year, are not aware of it either. There's systemic distrust of government programs. There's fear of costs. Many of these things I'm sure you are familiar with and can and could understand from your work with clients today. CMS's Division of Research in the Office of Communications has really identified three big categories of uninsured individuals based on how they consume information about health insurance. And SAMHSA's research really affirmed that individuals with behavioral health needs are represented in all three, and that the marketing communications work that CMS has done will work effectively for these individuals who have behavioral health needs. It's fairly straightforward, and the most important takeaway for us is that consumers with behavioral health needs do not want specific behavioral health messages about health insurance. They don't, and if you think about it, this sort of represents everything that we believe in as a behavioral health community, that behavioral health conditions are represented across the American population, and they don't predict the way in which we consume information, the way we behave. In fact, these other categories that are based on how we think about marketing and how we learn about health insurance are really the best ways of designing a marketing communications message. But the most important takeaway that I want to highlight for you all is that the research that CMS has done and that SAMHSA has done really highlights the importance of peers and trusted organizations as sources of information about health insurance. And for the clients that you serve who are uninsured, you really are a trusted source of information. And for that reason, we're really hoping to work with you to make sure that you're in a position to talk to them in an effective way about health insurance and about the enrollment process. Similarly, we found that this sort of reiterates that one-on-one assistance is really helpful, especially for folks with behavioral health issues. In order to help make sure that uninsured individuals with behavioral health needs are enrolled in coverage, SAMHSA is starting a program, hopefully by the end of this week the invitations will go out, called the Enrollment Coalitions Initiative. And what we're hoping to do is collaborate with national organizations like the Healthcare for the Homeless Council to make sure that you and other member organizations who interact with uninsured individuals on a daily basis are provided with more intensive training similar to what you're going through today on how to talk about health insurance, what the Affordable Care Act offers to your clients, and provide you with some of the excellent marketing and communications and education tools that CMS has put together. We're developing 6 national coalitions, including one specific to homeless service providers. So stay tuned. We're hoping to support each coalition group in a way that is targeted and helps you understand how to utilize the marketing resources that CMS has put together and take advantage of the improved application process that Anne Marie has overseen. And we're going to be starting with a conversation with the national organizations like Barbara in developing training and TA efforts that work with your setting, work with the way you do business. And then we'll be providing first a round of resources on health insurance literacy, and then we will be moving on later in the year to more intensive training on how to do enrollment assistance. Some of the other opportunities that SAMHSA is leveraging related to enrollment assistance are 4 purchase orders targeting racial and ethnic minority groups through our Office of Behavioral Health Equity. We are going to be developing best practices for community enrollment assistance for African American, Latino, Native American, and Asian American populations. In addition, we're working through the SOAR project to help develop a more intensive training module specifically for you and other organizations that work with homeless populations. And furthermore, in the future, all of the case managers that you have on your staff that may go through the SOAR training module going forward about how to help folks with the SSI or SSDI eligibility determination will also receive, as a part of that program, some additional training on how to build on that already complex eligibility process to make sure that if they are uninsured, they get access to the care that they need. In addition, we're doing an entire training module targeting enrollment assistance for the criminal justice population in partnership with the Illinois Task Group. Finally, there's 2 more groups that we're working with. We have a national peer and recovery community organization project where we're helping coalitions of peers and consumer groups learn about health insurance enrollment, learn about the Affordable Care Act, and make sure that families and peers and consumers are working with each other to make sure they're all enrolled in coverage. And I'm going to highlight a little bit more about the BH Business effort. Many of you are providers, and as you can see here on this graph on the far left, homeless service providers in particular, homeless shelters and other social services agencies that provide substance abuse treatment are the least likely to accept insurance payments. And as you can see on the right for mental health services, many of you I know are not CMHCs, but you can probably relate that many of them do not accept Medicaid or other forms of third-party reimbursement. In order to help provider organizations in particular learn how to participate in third-party reimbursement systems, how to set up billing systems, how to negotiate contracts, and especially for the purposes of today's meeting, do eligibility and enrollment determinations, SAMHSA has launched a national training and technical assistance effort on business operations. If you're interested in more, please also visit the SAMHSA Health Reform page. Here's the timeline that we're doing around the enrollment coalitions work. Starting hopefully by the end of the week, we'll be forming coalitions and going forward over the, as I said before, moving from health insurance literacy into enrollment assistance. So the key takeaways for me are that there's a high prevalence of behavioral health needs among the uninsured. We have the opportunity through the Affordable Care Act and the incredible work of our partners at CMS to bring coverage to 11 million individuals with behavioral health problems who are currently uninsured. And we really will depend on the work of your organization to make this happen. So I think that's all the time for me. Here's some more resources, including some outreach tools that we'll be providing to you more in the future. So please stay tuned. I think that it's now my pleasure to turn things over to Jessica.
Great. Thank you, Kevin. If I can just get my slides moved. Hold on one second. Fantastic. So my name is Jessica Kendall, and I am the Outreach Director for an organization called Enroll America. And I just want to take a minute to really thank the National Healthcare for the Homeless Council for putting this on, and also for everybody that joined today. We are so excited to be partnering with you all, and then as well as my co-presenters here. So Enroll America is a national organization. We are nonprofit, we are nonpartisan, and our whole goal is to make sure that Americans get enrolled in health coverage starting October 1st, which is actually in only 214 days, which for all of you on the phone doing math, that's actually less than 7 months. So the hearing from CMS and from SAMHSA has been incredibly helpful and informative. And as you guys are all hearing, there is a lot going on. I hope and assume many of you have started this already, but if you haven't, it really can start today. And there's a lot of different ways that you all can get involved in things that you can all be thinking about, not just from an organizational perspective, but also from a consumer perspective. So Enroll America, as I said, we are a nonprofit, nonpartisan organization. But really what we do is bring together wide varieties of stakeholders, anybody who has a vested interest in getting people enrolled in coverage. So we partner with HHS, the federal government. We also partner with healthcare-related organizations, health centers, hospitals, insurers, advocacy organizations, providers, anyone who wants to get people enrolled. And we do that at the national level by building coalitions, bringing people together to identify how activities can be coordinated, and then try to figure out how to take that work and move it down to the state and local level where you all are working with consumers. We will be having a national public education campaign, and that's based on information that we learned from some research that I'll be talking about in just a little bit. But the goal really is to identify best practices and then make sure that we are sharing those tools with you. We have a Best Practice Institute that has a ton of information available. It's on our website. But what it does is really identify what's working, what are the barriers to enrollment, and then how can we share that information with folks. We have publications and webinars, and then we help folks at the local level identify how to reach consumers. So looking forward, the Congressional Budget Office has estimated that there are going to be more than 40 million Americans who are going to be eligible for coverage in 2014. And about 15 million of them will enroll in the first year. So thinking about that universe, over half of the folks that they estimate are going to enroll are going to be doing so in next year alone. But what we know is just because coverage is available, it doesn't actually mean that people are going to enroll in it. And when you look at the adult Medicaid rate there, these are for the folks that would be eligible for a current coverage program. Only 67% of them have enrolled into a coverage program. So for us, the lesson and the takeaway is just because it's accessible doesn't mean people will automatically enroll. So we need to put together a campaign strategy that is builds on the success of past programs that do outreach and marketing, where you see that uptick in the number of people enrolled, but really does a lot more than what we've seen in the past because we have so many people to reach. And those folks are located in really a handful of states. So 12 states have 2/3 of the uninsured. And California alone has over 7 million uninsured folks. Texas has over 6 million uninsured. But every state has uninsured people. So we want to make sure that nationally we're sharing our resources with everybody, but that we also are mindful of where a majority of folks are. There's also one thing that most people have in common, and it's that they have no idea that coverage is going to be available. And I think that this is the thing to take special note of, because as we talk about all of the systems changes, they are absolutely essential to getting people enrolled, but people are not going to apply for a program that they don't know about. So over 4/5 of folks who would be eligible for Medicaid don't know that it's coming. And in our survey research, when we started looking at, well, here's what's going to be available. Do you want more information? People do, and they want it, and they're excited about it. But when we asked, would you need help applying for this, 3/4 of them said yes. And we also asked, well, how would you like that help? Because you do have all of these different options and ways to apply. A majority said they want that help to be in person. And I think that that's going to be vital for all of us as we think about how to plan for the future. So what we're doing at Enroll America is putting together this national campaign where we're going to be using data and analytics and micro-targeting and partnering with the federal government on this and with state-based exchanges to make sure that we're not duplicating efforts, but that we're complementing them on the ground level, but really trying to identify where the uninsured are and how we can reach them. We will have a grassroots field effort. We will have paid media. And everything that we create, we want to make it as easily and accessible to you all as possible, which is where we partner with the national organizations to make sure we can arm you with materials and information and research. We also want to make sure that we're using those really effective messages. So our research that I have mentioned, what it examined was who are the uninsured? Who makes the healthcare decisions for them? What do they need to know in order to want to apply? And what barriers are there going to exist for them to apply, or perceived barriers? And what's going to motivate them to check out those new insurance options? So we did a national survey where we oversampled target populations, with those groups that we know are more likely to be uninsured. And we also did this across a variety of income levels. And what we found when looking at this, well, one of the things we wanted to find was where are they at? How do they feel when they're looking for health coverage? And what we found is that they are stressed and overwhelmed and frustrated with it. Now, this would apply to the folks that would be eligible for Medicaid, also those who are eligible for the exchange. Regardless of whether or not somebody has had a past exposure to a public coverage system, they are still here. I don't know if any of you have ever tried to apply for insurance on your own, but it is a complicated process, or it has been in the past. So what we wanted to know is when you are trying to apply or figure out how to get health insurance, how do you want to feel? Because what we want to do is figure out how to motivate people to apply in order to give them the ability to get past those barriers and actually get enrolled into health coverage. And we took that idea of them wanting to feel confident and informed and secure and in control, and then we looked at all of the other surveys that have been done looking at people getting health coverage. So the Robert Wood Johnson Foundation did research among Medicaid population in a few states. HHS has done some research. A lot of the state-based exchanges have also done research. And there's a lot of similarities between our survey results and theirs. And the one that's the most interesting to us is that people want health insurance. So we don't need to try to sell this value of health insurance to folks. They already want it. But what they think is that they can't afford it. And if they can afford it, it's not going to be good coverage. And there's a sense of skepticism and confusion among folks that they've tried it in the past. Been really complicated and difficult. So they don't even want to go there because they know that they can't afford it. And there's so much fine print that if they did find an affordable plan, they're not going to be able to actually use it in the way that they're hoping to. And this resonates across all consumer groups. So what we looked at is regardless of your income level or your geographic location or your language, your ethnicity, is what do you need to hear? What addresses your barriers and where you're at, and what do you need to hear in order to feel more confident and secure? And what we found is those 4 messages that you all see resonate with 89% of the population. So nearly 90% of the population of the uninsured, if you tell them these 4 messages and combine them together, because different messages are going to mean more to different populations, but if you tell this to them, it brings them closer to that point of feeling confident and secure and wanting to apply. And so by knowing that there's going to be an insurance plan that will cover their doctor's visits and their emergency rooms and their prescriptions, and that they may have financial help, or for the Medicaid population, they may be able to get comprehensive coverage and not need to pay for it, and that there's not going to be any hidden fees or and it's all going to be in simple language. No matter what, they're not going to be turned away for a pre-existing condition. This motivates people to apply. And I want you to take one more second and stare at this screen, because regardless of what your organization does, this message can go to your staff, it can go to your coworkers, it can go to your community members, it can go to the clients that you serve. You know, we've had the last hour to learn a lot of information out there. And a lot of it doesn't need to be told to consumers. It's really good for us and our planning purposes. But these 4 points are absolutely essential if we want to make sure people get enrolled in coverage. And so the reason why it becomes vital for you all to be saying those messages is because people trust you. You know, there's a lot of us who are going to be seeking out uninsured folks to get them enrolled in coverage. There are countless numbers of organizations and entities who are trying to figure out how to enroll people, and all of them are trying to find the people that are already naturally going to you all. So again, regardless of whether or not you guys are helping people apply or if you are sending out information, the key thing is making sure that they actually hear that there's an option available from you, because you're the ones that they're going to be listening to. And so I put together a little action plan for health centers. You know, where do you want to be in 12 months from now? So in 12 months from now, open enrollment has been open for quite a while. It's past January 1st. Medicaid expansion in most states is going to be in existence, ideally. So where do you want to be in 12 months, and what do you need to do in order to get there? And then what do you need from your staff? Do they need training? Do they need education? What does your staff need to do in order to serve your patients or your clients in the way that you're hoping to? You know, there's been mention of the certified application counselors earlier and of navigators. In some programs or in some states, there's even going to be in-person assisters. So there are ways that people can, regardless of which funding stream it may come from, there's ways that people can be providing application assistance. And if that's something that you want to do, start thinking about what steps do you need to take in order to make that happen. And how, if you do that, can you coordinate with other people in your community so you're not duplicating efforts, but you're complementing the work of other folks in the community. And if you're not able to do that for capacity, then how can you partner with other organizations in your area that will be offering application assistance and that could then partner with you to perhaps house somebody in your health center or clinic or in your building that can be providing application assistance to your clients, and then perhaps your caseworkers could even be doing warm referrals to you. Now, make your data work for you, I think, is an interesting one. So who do you see right now? Who's coming to you? And I imagine that quite a few of you see folks where you don't actually have a resource for people who need health coverage. You don't have the ability to get them enrolled on a plan, especially if they're seeking services that you don't have the capacity to fill within your clinic. So how can you look at those folks and connect them with health coverage when it becomes available and connect them with that health insurance? And if you do have clients that happen to already be on Medicaid, how can you make sure that they stay on it through the transition? And lastly, everybody that you are in contact with, again, in your community, at your center, in your clinic, they all have a role in outreach, and it extends far beyond sitting down with somebody and helping them fill out an application, which is absolutely essential and necessary, and we know 75% of people want it. But the bigger thing is nobody knows that they need to ask for it. 83% of the folks that you're coming in contact with in your daily life have no idea that this is coming. So when you start thinking about outreach, know that it extends beyond application assistance to really looking at information dissemination. And as you look forward this next 12 months and over this next year to figure out what your plan is, know that there are a lot of different groups that want to make sure that people get enrolled in coverage. And by coordinating our efforts at the local level, we can make sure to actually reach all of the uninsured that are out there. At Enroll America, we try to facilitate these conversations and foster them. Barbara and I talk regularly, as well as Kevin and myself from SAMHSA, and then we're having regular meetings with CMS. So if there are things that you need at the community level, we would absolutely love to help you with them. And the National Council is a wonderful organization to turn to for resources. And I guarantee if there's something that you need, somebody else needs it as well. So making sure that you're making those requests rather than reinventing the wheel will be absolutely essential. If you do want more information on our research or on any of the briefs that we've written, we have a couple out there on best practices in health centers. And we also have on our website information about what's happening in each state and any of their outreach plans. You can go to enrollamerica.org, and we would love to share it with you. And if we don't have time to get to some of your questions, please feel free to follow up with me. Thank you.
Thank you, everyone. Jessica, Kevin, Stephanie, and Anne Marie, that was really phenomenal. I know you covered a lot of ground in a short amount of time, and we've had a number of questions coming in. In particular, one question that I know we've gotten frequently, and I've seen roll over as well, is how is it that people who have no income, such as many of our clients experiencing homelessness, if you are verifying against the IRS and there's nothing there, they haven't filed taxes, there's no income, can you make a comment, Stephanie or Anne Marie, about how that will be handled in the verification process?
Well, the verification practice may vary from state to state, but our regulations allow for a state to just accept self-attestation. So a person can just attest to their income. And if they can't be found in a data match, there was not likely a need to prove that. So if you say you're unemployed, you have zero income, and there's no match in the state's quarterly wage reporting system, there's no reason to think that there's any inconsistency. So a state can choose to accept self-attestation.
Excellent. Thank you. One question we had that came in was about exclusions, such as criminal convictions for drug distribution or filing an application for citizenship. Do these exclusions still apply? And Anne Marie or Stephanie, that might be for you.
Yeah, so I would say there is no requirement for someone to be a citizen to participate in Medicaid. They can be a citizen or a qualified immigrant. So there's no need to apply for your citizenship. I think the question, or I read one of the questions also asked around 5-year issue, and, you know, PERORA, which was welfare reform, and then immigration reform back in, I guess, 1997, changed some of the rules and set limits on when particular individuals can participate in programs, and some individuals need to wait 5 years to participate, so some immigrants need to wait 5 years to participate in a public benefit program. Some states cover immigrants during that time. There's particular options to cover children and pregnant women during that time, so it a little bit varies from state to state, but I do want to affirm that there is no citizenship requirement. So someone could be a citizen or a qualified immigrant. And there is no criminal history factor for eligibility. So I'm not sure if that's getting mixed in with other public benefit issues. Because oftentimes individuals applying for Medicaid are also applying for other public benefits.
Excellent. And then along the same lines, we've had another question. How will the new changes impact incarcerated people? And Anne Marie, maybe this is a Medicaid eligibility question.
So I was going to say, this is Stephanie, individuals who are incarcerated, at least in terms of Medicaid, they're not ineligible for Medicaid. The state just can't get any federal matching funds for covering their services while they are incarcerated. So the individual would be eligible, and then once they are released, they could then receive services under Medicaid. In terms of the exchange, I believe they actually do have rules around incarceration.
Yeah, they have slightly different rules around incarceration. Barbara, what I would add is that I think because with the expansion of Medicaid eligibility, that I think there'll be more efforts focused on ensuring that individuals that are released, incarcerated individuals that are released, have access or get enrolled in Medicaid, many of which, and Kevin, I'm sure you could say much more about this, the need for access to prescription drugs in particular, so that they can have more immediate access to care. So I think that there'll be some greater focus today with the opportunity, particularly around the expansion.
Excellent. We're getting questions about how people get certified as an application assister. Can you respond to that?
That'll be a state-by-state basis, so agency, providers and others will need to work with their state Medicaid agency or their state or the exchange serving their state. So I think there's nothing to do right now. I think there's detail to come. So I would stay tuned for those kinds of developments. And Barbara, maybe as we know more about processes and procedures, we'd be happy to come back and talk more about that.
Excellent. This might be a question for Jessica, but it could apply to everyone. Who can come to my nonprofit to do a presentation? And I think this reflects a lot of questions we got about how people access training and further information in their communities. What would be the best place for people to go to find out more information about what would be available to them locally?
Absolutely. I think similar to what Anne-Marie just said, it will be dependent on your state that you're living in. In a lot of states, there are community-based organizations and entities and even exchanges that are doing presentations and talking about it right now. In a lot of states, there's also groups that are looking for more information. So on our website, there's a map on enrollamerica.gov, or .org, excuse me. There's a map of the U.S., and you can click on a state, say Oregon, and you would see in Oregon a link to the exchange and information that's out there. Depending on your state, you can also shoot me an email and I can let you know if there are any entities that we are partnered with at the local level. I can say that there will be a lot more folks, navigators, application assisters. There's going to be a lot more folks over this summer who would have the training and capacity to come do presentations on this.
And this is Kevin. I want to follow up to say that for homeless serving organizations, we're going to be developing a series of training efforts that are not going to be in person, but depending on where you're located, SAMHSA's regional administrators may be able to come and speak to you further if it's feasible with their travel. But at the very least, there will be materials and some forms of electronic and virtual training specifically targeting organizations that serve homeless organizations. And then to sort of echo what Jessica and Anne-Marie were saying, there will be, depending on the state level outreach and enrollment assistance infrastructure, additional state-specific training, which I would say would be the best opportunity. That would be the stuff that Jessica is highlighting or that is state-specific, because what we're going to be putting together is very general and helps organizations find state-specific enrollment information and application information. So I think it's going to both vary, but there will also be some national resources. And then finally, the CMS Office of Partner Engagement is developing a series of trainings at the very high level, sort of 101 level resources that will also be available for organizations.
Thank you. And Kevin, this also is a follow-up question to some of your discussion about the SAMHSA Enrollment Coalitions Initiative. How will providers join those coalitions?
It's a good question. So providers will not themselves be joining the coalition. The coalition is for national organizations that represent them. So if the goal is that all the entire range of community-based organizations that have contacts with uninsured individuals with behavioral health needs will get the opportunity to push training out to their members. So the coalitions themselves are about 50-plus national organizations that represent professionals, individuals, and organizations at the community level.
Thank you. Anne-Marie, this is a technical question on eligibility. Will Medicaid applicants still be able to apply for 3 months of retroactive activity? Will applicants for the Affordable Assurance Program also be able to apply for retroactive coverage? And if yes, for how many months?
So let me do the first part. Nothing changes about retroactive eligibility. You'll see when listeners on the phone look at the model application, there is a question that asks about medical bills in the previous 3 months. That's to set a flag with the Medicaid agency to follow up for that with that individual so they could determine their eligibility during the retro period. If when they say the affordable insurance programs, if we're talking about exchanges, exchange eligibility is prospective. So there is no retroactive eligibility for someone enrolling in a qualified health plan through an exchange. We did not talk a lot about exchange eligibility. I mean, there were different eligibility requirements. You know, exchanges have an open enrollment period. It works much the same way as employer-sponsored coverage does. So the initial open enrollment period begins October 1st, 2013. And I'm going to admit, I don't know the end date, but it's either February, I think it's the end of February 2014. Though individuals can have a special enrollment period, so a change in their circumstances that trigger their eligibility to be considered. So I'll leave it at that. But there's a lot more that could be learned around eligibility for enrollment in a qualified health plan.
Excellent. And then just more questions about the certified application counselors. Where should people go for more information to find out about what that process is going to be, given that that's a state-by-state decision?
I'll start, and maybe our friends from Enroll America might jump in. But again, it is state-by-state. I think they'll need to wait until the rules are finalized and states get their online applications up. I mean, I think it's going to be a couple of months, and I can't say any more than that right now.
Got it.
Jessica, I don't know if you will have more, or you think in the future?
We'll be keeping folks up to date as soon as we learn more information. What we've really been encouraging organizations to do, and if you disagree with this, please say something, Anne-Marie, but, you know, for certified application counselors and also for navigators, because this information is kind of a game of hurry up and wait, we're trying to figure out, it's a good time for organizations to be thinking about what role they want to play, because by the time we're able to get the information, especially about navigators, there's going to be a really tight turnaround. And for certified application counselors, in both federally facilitated exchanges and then also at the state level, we want to make sure that you all have time to identify how many staff people should be trained, where those trainings exist, and how you can be prepared for October 1st, 2013. So although the information doesn't exist, I think it means that you can still be planning for it. And you can check our website for regular updates. Anybody that's in a state-based exchange, most likely there's also a website that is updating on a regular basis any plans that have been made. And you can link from our website to all of those websites.
And would you say, Jessica, that's also a good place to find, so that's also good for information on exchanges as well? We've had questions about how people find their exchanges.
Absolutely. I believe on our website we have a slide that shows a map of the country, and then it has what the status is of each state. So, you know, Oregon has a state-based exchange and is going to be doing a Medicaid expansion. So it has a breakdown for you to be able to visually look quickly at what the status of your state is. Then you can also get links to whether, if there is a state-based exchange, you can access their website from ours.
Great. And then that'll also answer questions that we've gotten regarding how one finds out if your state has decided to expand Medicaid. Jessica just described the maps that are on their website that are color-coded, so you can not only see where your state is, but you can also click on that state and get connected through Enroll America to a wealth of resources. That has been a tremendous compendium of material, so really want to tip my hat to Enroll America for putting that out for everyone.
Barbara, if I could this is Anne-Marie, if I could just give a second resource, healthcare.gov has so it's healthcare.gov is the national website, is the federal government's website, and there is a section on there about the marketplace, and that's what we're calling our exchange, the marketplace, and individuals can go on there, learn more about the marketplace and also sign up for alerts so that they can get when there's new news on the website.
Oh, excellent. Good. And I think this reflects a lot of questions we've had for how people keep up with information. So signing up for the alert sounds like a good idea. A question we've gotten, and I think a lot of people hear a lot about the individual mandate and the fines that are associated with not having insurance. And when we connect that with the information that Jessica had outlined in terms of the take-up rates, it's reasonable to think that we're not going to be able to reach everyone quickly. We're getting questions about when does the fine start for not being enrolled?
So that's really an IRS question, and I can't answer that, but I think I'd like to say two things. The individual responsibility starts at, I think, not before 100% of the federal poverty level, so it's not applicable to everyone, and it's just a reminder that Medicaid is health insurance and would count. So if someone has Medicaid, they would not be subject to the individual mandate.
And then also, it's my understanding, and Marie, correct me, that those who are below the filing threshold will be exempt from getting the fine. Is that correct?
There is a threshold. I'm not sure if it's the filing threshold or if it's 100% the federal poverty level. We could check that for you.
Okay. So I think it's my understanding, though, that for folks who are serving people who are homeless and have got very low incomes, that if you are below that threshold, then the fine doesn't apply to you, and that, as Anne-Marie discussed, the fine is assessed through the IRS. And one of the things that I know is that very few of our members, anyway, in the Healthcare for the Homeless grantees, have clients that file income taxes. So I think these are a couple of factors that will mitigate the financial harm that will come to our clients if they're not enrolled. But again, of course, we're taking every step that we can to get them into Medicaid, which, as Anne-Marie said, counts toward the requirement. So real quick question, a final question, and I think maybe even for this week, the most appropriate final question. How does the sequestration affect all of these changes and the new things that we've talked about for the last hour and a half? And it may be a hot potato button that we're not quite sure yet, but in particular, our federal funds, is there any indication yet on what this really will mean?
We don't have any information at this point.
Okay.
This is Jessica. I mean, Enroll America doesn't have information on it, but we've been having conversations about getting folks enrolled in coverage for really the last year and a half. And one of the things that we found is that, you know, people weren't ready to plan. They were holding back because of the Supreme Court decision, and then because of the election, and then decided whether or not their state's moving forward with the Medicaid expansion. And for a lot of states, folks aren't going to know about the Medicaid expansion until after legislative session is done, which could be June. So when it comes to this type of question, I feel like there is so much work to be done and so much to plan for in the next 214 days that, you know, whatever the government decides to do over the next few weeks, we will be moving forward in 214 days. So I would highly encourage folks to start looking at what you want to be doing next year to figure out what steps you need to do to get there.
Thank you. That is the end of our questions. For those who are still with us and attending, we've got a lot more information on our website and at these resources. Our colleagues here at CMS and SAMHSA and Enroll America also have a wealth of information on their sites. These slides will be posted, and the recording will all be posted on our website as of tomorrow morning, and we will be emailing a link to those materials in the morning. So everyone will get connected to all of this. We do encourage folks to check out our website, consider attending our conference, and then also, again, know that we will be sending out information about this tomorrow morning. Please note that on our health reform website, we also have a sign-on letter. Anne-Marie had mentioned that the draft regulations on the application are out now. We're really trying to circulate information so that people are aware of how that application will roll out. Please consider looking at the comments we've put together. Also, at the close of this webinar, you'll receive a survey. Please fill it out so that we can improve our future webinars. And really just want to thank Anne-Marie and Stephanie and Kevin and Jessica for their expertise in sharing with our community. Really appreciate all of you coming today and talking with us and sharing this information.
Thank you.
And with this, we will be ending the webinar. Again, thank you to everyone who's joined us today.